A healthy 20-year-old, non-sexually active female presents with a complaint of a sore throat. She is febrile and mildly tachycardic. On evaluation, she looks uncomfortable but is in no distress. She has cervical adenopathy, and direct visualization of the oropharynx reveals symmetric tonsillar erythema and diffuse exudates. Ideal management for this patient would include which of the following? A. Ceftriaxone, 250 mg IM once. B. Ibuprofen, 400 mg every 4 to 6 hours, dexamethasone 10 mg once, and acetaminophen oxycodone 5 by 325 mg QIDPRN. C. Ibuprofen 400 mg every 4 to 6 hours, penicillin G IM once. D. Ampicillin sulbactam, 3 grams intravenous, and incision and drainage. Answer is C. Ibuprofen 400 mg every 4 to 6 hours, penicillin G IM once. Usually, sore throat is caused by acute pharyngitis, in which case pain management with acetaminophen or NSAIDs is the mainstay of care and the most important initial step in empirical management. The center criteria, incorporating components of the history and physical examination to generate an estimate of group A streptococci, gas, with the results of one classic study, and this patient would be a candidate for antibiotic treatment. What is the most common cause of trace hemoptysis, blood-tinged sputum? A. Bronchiectasis. B. Bronchitis. C. Cancer. D. Congestive heart failure. E. Pulmonary embolism. Answer is B. The most common cause of small volume hemoptysis is bronchitis. Disruption of which of the following vessels is responsible for the vast majority of cases of massive hemoptysis? A. Aorta. B. Bronchial arteries. C. Pulmonary arteries. D. Pulmonary veins. E. Tracheobronchial capillaries. Answer B. Massive hemoptysis almost exclusively involves one of the two sets of vessels that constitute the lung's dual blood supply. Bronchial arteries, direct branches from the thoracic aorta, are responsible for supplying oxygenated blood to the lung parenchyma. Disruption of these vessels can result in sudden and profound hemorrhage. Although small in caliber, the bronchial circulation is a high-pressure system and the cause in nearly 90% of the cases of massive hemoptysis requiring embolization. Although they transmit large volumes of blood, pulmonary arteries are at much lower pressure and, unless affected at a very central location, are less likely to cause massive hemoptysis. Trace hemoptysis typically originates from tracheobronchial capillaries that become disrupted with vigorous coughing or minor bronchial infections. Which of the following statements regarding the evaluation of hemoptysis is true? A. Chest computed tomography, CT, should not be obtained in patients with massive hemoptysis if this delays initiation of bronchoscopy. B. Chest CT should be obtained in any patient with moderate bleeding even if the initial chest radiograph is normal. C. Conventional angiography is the preferred diagnostic test to detect both bronchial and non-bronchial arterial causes of massive hemoptysis. D. High-resolution multidetector CT, even with recent advances in technology, remains diagnostically inferior to angiography. E. In patients with massive hemoptysis, plain films accurately localize the site of hemorrhage in less than 50% of patients. Answer B. In patients with massive hemoptysis, plain films may localize the site of hemorrhage in as many as 80% of patients. However, high-resolution multidetector CT of the chest is the principal diagnostic test to detect both bronchial and non-bronchial arterial causes of massive hemoptysis. CT is diagnostically comparable with, but less invasive than, conventional angiography, which currently is done as a combined diagnostic therapeutic modality. A chest CT scan should be obtained in high-risk patients, smokers and oncology patients, or in any patient with moderate to severe bleeding even if the initial chest radiograph is normal. CT localization of hemorrhage can expedite bronchoscopic evaluation or guide subsequent interventional procedures.